Hi, this is Herb Kressel, and welcome to the Radiology Podcast. Today, I'm joined by Dr. Andrew Rosenkrantz, Associate Professor of Radiology and Urology at the New York University School of Medicine. Dr. Rosenkrantz and his colleagues authored a fairly definitive paper entitled Diffusion-Weighted MR Imaging for Detection and Assessment of the Aggressiveness of Prostate Cancer, Comparison between Conventional and Kurtosis Models. Welcome, Dr. Rosenkrantz. Thanks so much for joining us.
Thanks so much for having me.
Sure. Now, many of our readers may only be peripherally aware of kurtosis, diffusion kurtosis imaging, and its impact in assessing the aggressiveness of prostate cancer in particular. So could you tell our listeners and viewers what actually is diffusion kurtosis?
Okay, so I would compare diffusion kurtosis imaging to conventional diffusion-weighted imaging, which assumes that that the water diffusion is free in its behavior. Diffusion kurtosis imaging recognizes a broader range of hindrances to water diffusion and can account for those hindrances in its modeling to extract information about the microstructural complexity of tissue. It can look at how complex the tissue is at the cellular and even the intracellular level.
So the more complexity of the tissue, the less free the diffusion is, and that would affect the kurtosis. It also affects the distribution of the diffusion parameters.
Correct.
Okay. So with that as a basis, why would you think this kind of a metric might be of value in assessing the aggressiveness of prostate cancer in particular?
So for assessing the aggressiveness of prostate cancer, we're really talking about the Gleason score, which currently it's a score that the pathologist determines on their visual assessment, looking at the tissue under the microscope, that is really driven by the architecture, the complexity of the tissue in its appearance. The conventional ADC is kind of this hodgepodge or amalgamation of effects, also influenced by the tissue viscosity, other factors, and the hypothesis is that the diffusion kurtosis is more of a kind of a pure or less contaminated reflection of really just the of just the structural complexity and hindrances, which it's believed could more reflect what the pathologist is trying to estimate when they assign the Gleason categories.
Thank you. Now, this study is a follow-up to your own, which we published in 2012 as a preliminary assessment of diffusion kurtosis imaging in prostate cancer. And since that one was published, there have been several others published. And the results, as you note, have been mixed. So why did you think that this current study you're reporting could more definitively determine the utility of kurtosis in looking at the aggressiveness of prostate cancer? Were there particular problems with the prior studies?
Yeah, so the studies this has been a topic of a lot of interest in the last few years. We're all trying to best predict the Gleason score non-invasively, which has huge implications for prognosis and treatment selection. And the studies have had mixed results. Some have been really promising, others have not been. So in terms of some of the limitations of what's been done is the sample sizes have generally been small. Some have used as a reference standard biopsy instead of radical prostatectomy,
Right.
as we did in our initial feasibility study of kurtosis in the prostate, which has it's using biopsy that's limitations in terms of the precision of the grading, and even just some technical factors in terms of how the kurtosis image sets are processed and the metrics are obtained. I think some of our understandings of this have evolved and improved over the last few years. And I think in terms of what B values from the diffusion acquisition are incorporated and how this is done, it's not just just pushing a button. There's a lot of optimization of the kurtosis. I think even that has gotten more precise as well.
Good. Now, can you briefly outline what you actually did in your study? Tell us a little bit about the design and sort of what you looked at.
Okay, so we had a retrospective sample of several hundred patients at our institution. Our standard diffusion acquisition provides the necessary information to be able to extract the kurtosis metrics. All the patients underwent prostatectomy after MRI. We included patients where where pathology had done detailed mapping of the distribution of tumor within the prostate, including localization and grading of individual tumor foci. We then selected the dominant or indexed tumor in each patient and correlated these back to the imaging and placed regions of interest to obtain what we deemed to be the optimal standard ADC and the optimal kurtosis metric that we could generate using our acquisitions.
So were these mean ADC and mean kurtosis over the whole volume?
These were it was the mean it was the mean value of an ROI on the entire lesion. And then we correlated that back to the pathology, and we looked at the ability of ADC and kurtosis to predict a range of outcomes, to separate benign versus malignant, as well as to separate low-grade from high-grade tumors using two different definitions of high-grade that have been applied in the literature. So we really had three different histologic outcomes for which we compared conventional ADC and kurtosis.
Okay, and what were your key findings?
So in terms of our findings, we found these interesting. So ADC and kurtosis, they were highly correlated. Basically, as ADC goes down, kurtosis goes up. Both of those show being generally associated with greater aggressiveness. Their accuracy for predicting our various endpoints, benign versus malignant or high-grade tumor, were very similar. And when we looked at the subset of patients where they say there was a difference between them, kurtosis actually did not outperform ADC even in that subset. So either they generally they basically gave the same prediction, and for most patients they predicted the same thing. Either both ADC and kurtosis said it'd be benign or it'd be high grade, or both of them said there'd be they both gave similar results, or basically giving basically somebody's giving some redundant or repetitive information from the kurtosis that we already had from ADC. And in a small minority, when they were discrepant, the ADC actually did similar, even a little better.
Okay. So although in the paper you described what I would consider a fairly rigorous protocol for matching the images, particularly the target lesion with histopathology, in 36 patients, the target lesion couldn't actually be identified on the MR images. Were you surprised by this, and why do you think it might have happened?
So that's a really important point. Those were overwhelmingly low-grade tumors. These are Gleason 6 lesions, and this is recognized actually in prostate cancer. And this comes up. This is a recurring issue when we try to do detailed MRI pathology correlation for prostate cancer. And other groups have described, other universities have described this as well. Some prostate tumors, they don't really form a discrete mass, like say a renal cell carcinoma. It's just, it's histologically sparse. The malignant glands are interspersed with benign glands. There's really no actual discrete tumor, and these can actually just be invisible on imaging. So for those, we had no clear correlate on the imaging. And for those in our final analysis, we ended up basically looking at the numbers both ways, where we just empirically placed an ROI and where it seemed the lesion was based on the pathology versus just excluding those. and we had similar whether we did an empiric ROI or left those on, we had similar our final observations held true.
Okay. Now, although the ADC and the kurtosis findings were correlated and concordant in around 80%, as you noted, they were discordant in around 20%. And you mentioned that in these, a majority of them, the ADC was sort of more accurate, or at least correlated better with the histopathology. But my question is, what do you think is driving the discordance? And what sorts of lesions did you notice this discordance?
Well, I mean, the ADC and kurtosis, they were correlated, but there are differences. The ADC does have influences from viscosity, concentration. There are some other, it's kind of more of this messier metric. Mm-hmm. Whereas the kurtosis are really more tuned into complexity and hindrances to water motion. So there will be there will be a small fraction where they didn't exactly follow each other. I can't say exactly what the unifying kind of property was of the lesions where that happened, but that it was not common, and the ADC did what was either similar or a little better than kurtosis in that.
So what you're saying is that they are, in fact, although they're related, they're measuring somewhat different things, and it's not surprising that the measurements wouldn't be the same in some subset of patients.
Exactly.
So now, as we said, in your study, you looked at whole ROI, or most of the lesion volume, ADC and kurtosis. Others have started to look at subsets, doing histograms of the ADC and the kurtosis, looking at sort of the worst actors, the bottom 10%, bottom 25%. And have you looked at other kurtosis-based metrics?
So I think the histogram metrics for extracting a summary value from diffusion acquisitions is really promising. So say looking at the 10th percentile or the skewness, this has shown, I think some really compelling results in the prostate, as well as a range of other organs, work from other centers, work that we've done at NYU. And I think unlike the diffusion kurtosis technique, this doesn't really require any changes or adjustment in the protocol. A standard protocol can be done, and it's all on the post-processing side. I think vendors are making those tools available, and this is kind of, I think, becoming easier to incorporate into clinical workflows. So I think this has a lot of potential, even in the near term.
The same thing with the kurtosis metric,
in this
histogram of it.
So, and this can be completely applied to the kurtosis data set, which we didn't do in this study. But I mean, it's a great idea. The literature has consistently shown incremental improvements in performance when applying the histogram analysis. So whether done to the conventional ADC, do a conventional diffusion analysis, it can be applied in a comparable way to the kurtosis data set. It wouldn't surprise me if that led as well to incremental improvement there. We didn't put in this study, we were just doing a comparison of conventional mean between kurtosis and standard diffusion. But I think I would anticipate that applying the histogram approach to either of these could bump up their performance a bit.
Yeah, I mean, histologically, as you know, the Gleason grade can vary throughout a lesion in scattered areas. And so it would seem that sort of, and my understanding is that the worst grade drives the final grade, so that this might more closely mirror what the pathologist is looking for in sort of finding the most aggressive areas to establish the grade. So I agree with you. It sort of makes sense as an area for future investigation. So this sort of leads up to my final set of questions for you. And so it sounds like you haven't given up on kurtosis yet. Are you still acquiring this data in your patients?
Well, we're looking at, I think more can be done to optimize it. And there might be some additional ways of, some additional angles that haven't really been as well explored or considered. So no, we haven't given up on it. I think it can be something that can be combined with some other innovations. So as an example, more recently, what we're turning our attention to is is time-dependent diffusion. This is a parameter that hasn't gotten quite as much attention by radiology investigators. A lot of the focus has been on the B-value and directions of the underlying diffusion acquisitions. There's also the actual diffusion time, the time between the diffusion sensitizing gradients actually can be manipulated. It's playing with the actual source sequence. The vendors don't always make this as readily available to us as radiologists to work with, but it actually can be adjusted. And we're finding that can actually, we can actually push it to really short diffusion times, shorter than are usually applied, and can effectively tune the contrast of the diffusion image sets in that manner. We can actually then go back and combine that with the kurtosis analysis or the conventional diffusion analysis, and then we're finding some really interesting results that way. So we're still using kurtosis, but the idea is to combine this with some other manipulations of the diffusion acquisition, and then we'll see what all this shows over time.
Well, it sounds like there may be another radiology podcast in your future as you get more into this work. Well, Dr. Rosenkrantz, it's been a pleasure chatting with you about this paper. And I think at this point in time, it certainly gives us a good handle on the relative role of diffusion kurtosis imaging in looking at prostate cancer aggressiveness. Thanks so much for joining us.
Thanks so much again, and I really enjoyed participating.